Today we are going to talk about wearing off. What option do you have if you are wearing off 1 hour, 30 minutes before the next pill in the setting of Parkinson's disease? For example, if you take carbidopa, levodopa, 25/100 milligrams, 1 tablet 3 times a day, and you are wearing off half hour, 1 hour before the next pill, this video is for you. You might experience sometimes symptoms such as more slow movements, more stiffness, more tremors, even feeling anxious, even feeling shortness of breath because increased stiffness in the thoracic cage. If this sounds familiar for you, watch this video. Okay, let me start by saying that if you have Parkinson's disease, you will have this problem at some point. It might take 2 years, 3 years, some people even 5 years, some people even more. Everybody is totally different. So you cannot compare yourself with your neighbor, with other patients. Everybody is different. So let me give you an example. Imagine that you wake up usually at 6:30 a.m., right? And you go to bed at 10. And you take the carbidopa levodopa, which is the typical medication that we use in people with Parkinson, 3 times a day, 1 tablet, 25/100 milligrams. But after a few years, maybe 2, 3 years, some people even 5 years, or some people even more, you start wearing off. So which means that the medication is out of your system, out of your brain, so you have more Parkinsonian symptoms. What to do? And I'm going to discuss step by step. Step number 1. You need to ask yourself if this problem is affecting your life, your daily activity. So if you are wearing off half hour, 1 hour before the next pill, and it's affecting your life, then you need to do something about it. Otherwise, you don't need to do anything. You don't need to treat every single symptoms in Parkinson's disease. So if it's not affecting your life, maybe the only thing that you have to do is just make sure that you are doing a good routine of exercises and eating well. And maybe trying to separate the pill, the levodopa, the carbidopa levodopa, from proteins. Sometimes that might be enough. In some patients, not every patient is susceptible to this potential interaction between proteins and levodopa. Those patients that are more predisposed to have this potential interaction are younger patients and also patients with a strong family history of Parkinson's disease. And I have a video about when should you take levodopa. Should you take the levodopa with meals or without? The link of this video will be in the description below. Now, if the answer to the question is yes, this problem is affecting my life, my function, then you need to do something. And something means many options. Let's start with the simple one. So, again, you are wearing off half hour, 1 hour before the next pill. So, which means that sometimes I ask patients, how do you know that you have to take the next pill? Because of the clock or the way that you feel? So those patients that are wearing off, they usually, almost always tell you, is the way that I feel. So they feel more Parkinsonian symptoms. So more tremors, more stiffness, more anxiety, more slow movements. So the easiest step to do is, if you take the medication 3 times per day, imagine that you take it at 7 a.m. and then at noon, 12 p.m. and then at 6 p.m. So maybe the only thing that you have to do is just to increase the amount of tablet that you take per day. So for example, instead of taking 3 times a day, you will take it 4 times a day. So which means that every 4.5 or 5 hours while you are awake. That might be enough to solve the problem for now. That's step number 1, and the easy thing to do is just to increase the amount of pills from 3 to 4, or maybe from 4 to 5. So extra 1 pill. If step number 1 doesn't work for you and you have the money, the resources, you can change to these 2 type of levodopa formulation, Rytary or Crexont. These 2 formulations of levodopa are a very sophisticated way to deliver levodopa to your brain, combining a short-acting with a long-acting levodopa, giving you approximately a little bit more than 1 hour on time per day, which might be enough for you, and probably the only thing that you need to do at this time. However, they are very expensive. So I always compare these like driving a Ferrari. You still can get to point B from point A, but it's like less bumpy. That's the way that I describe this. Now, the conversion, if you are taking the regular carbidopa levodopa that we call the IR, the immediate release, and you try to convert from the IR to Rytary or Crexont, it's not too easy. That requires your provider to follow up with you closely, because it's not straightforward and require adjustment. Usually, some lucky patients, you just switch. For example, Rytary, I usually double the dose, and that might be enough, and patients are doing fine. But I will tell you, more than 50% of the time, those patients require adjustment. Either I'm giving them too much or too low. The same thing applies with Crexont. Now, sometimes before trying these 2 expensive medication, Rytary or Crexont, I just add the Sinemet, the regular carbidopa levodopa, but not the IR, the ER, the extended release, and some people call it continuous release. This medication is not actually a extended release technically, because the actual standard release are Rytary and Crexont. So the problem with this medication, this formulation, the ER, is the absorption is not good compared with the IR. So it has a very erratic absorption. So you never know how much you are going to absorb. Some data suggests that you absorb only 70% of the levodopa. So I tried because it's cheaper by far, and some patients respond. Some patients might have at least 1 or 2 hours extra per dose when compared to the IR. So if you are one of those lucky patients, good for you, and it's good to try. When I use a lot or more frequent the ER, the standard release Sinemet, the regular one, is at night. So at night tend to work better. So sometimes when patients are complaining of nocturnal symptoms, which could be even insomnia, or could be that they wake up at 3 a.m. with severe leg spasms, for example, the right leg spasm, contraction. Sometimes adding the ER formulation could be 25/100 or the 50/200. That might be enough to improve quality of life and to improve the sleep. So it's good to try. And sometimes what I do is just imagine that you are taking the carbidopa levodopa IR, the regular one, usually yellow pill. I sometimes just add the 25/100, the ER Sinemet, at the same time. So one of each one. And that might be enough. And sometimes I need to do that because the insurance asks me to do it before thinking about Rytary or Crexont. So sometimes you have to do it anyway. Next step, if after changing to Rytary or Crexont, you still don't feel that is working for you, so it's not making the trick, then you might need to add what we call entacapone or opicapone. Opicapone is very, very expensive, so I will try first entacapone because it's cheaper, although you have to take it more frequent because it's a very short, it has a very short half-life, so approximately 1 hour, 1.5, 2 hours as much. But opicapone is a very long-acting medication, it's once a day. So obviously if you can afford opicapone, that's the way to go as a next step. Now, after playing with all the oral levodopa formulation that we have available and adding either entacapone or opicapone, and still you're wearing off 1 hour, 30 minutes before the next pill, you need to add another medication. But everything depends of your comorbidity. So what other diseases, what other conditions you have around you. Because remember, all the medication that we use, especially in the setting of Parkinson's disease, they have side effects. So everything depends on what other condition do you have. And remember that still in 2025, the best medication that we have available for motor symptoms in Parkinson's disease is Levodopa. There is nothing better than that. Beside exercises, of course, and a good healthy diet, but still you need Levodopa in order to function. Now, this is the order of medication based on my preference and data, and some comorbidity. So everything depends on what you have around you. Remember. Now, if I'm going to add another medication and I play already, I adjust all the levodopa oral by mouth, oral levodopa that I have available, and I need to add something else, then I will start with this type of medication, these two, what we call Azilect or selegiline. Azilect or selegiline. So these two medications keep the levodopa more time in your brain. Okay, and especially if you have fatigue, which is a very common non-motor symptoms in Parkinson's disease, I think this is the way to go. You try these two medications that they tend to be very safe. Azilect is once a day, and the doses are the therapeutic dosage is 1 milligram. I always start with half of the tablet, 0.5, but after 1 week, I tell the patient to go up to 1 milligram, and you have to take it in the morning. Selegiline is twice daily, 1 in the morning and 1 with lunch. Okay, don't take it too late. Why? Because selegiline is metabolized to amphetamine, and technically it might cause insomnia. So, and that's why there's one of the reasons why we give this to patients with fatigue. So now there is a concern that I always get a letter from the pharmacy because I prescribe this medication in patients who are taking SSRIs like Lexapro, Zoloft, and the pharmacist, obviously, because FDA put this like a red flag, that it might cause serotonin syndrome. But in more than 12 years working with patients with Parkinson, I have not seen never a serotonin syndrome, not even in the ICU, that I work in the ICU as well. So this is a very rare phenomenon, and even less common in patient with Parkinson's disease. So as long as you take the correct dose, and you don't take an extra dose of selegiline and Azilect, I don't think you should be worried about serotonin syndrome. But I have to tell you, and I tell patients that the pharmacist will tell you that you cannot take selegiline and Azilect if you are taking any of those SSRIs or SNRIs or tricyclic antidepressant like nortriptyline, that kind of medications. Now, the other medication, the next step, if I need to add something else, is Amantadine. So Amantadine, especially if you have dyskinesia, which is a dancing-like type of movement, and significant resting tremor, Amantadine, I think, is the way to go. And especially if you have drooling or dystonia, because Amantadine, it has some, what we call in medical terms, anticholinergic effect, which means that it might improve the tremor, the dystonia, and the drooling because it causes dry mouth. But pay attention to the side effects of this medication, because they are not nice side effects. So if you have cognitive issues, so memory issues, or you have hallucinations, or you have leg swelling, this medication might not be a good choice for you. So you have to be careful, because this medication, especially on those patients that they already have cognitive memory issues, might not be a good choice. It might make things worse. But unfortunately, Amantadine is the only medication that we have available for dyskinesia, which is a dancing type of movement that is caused by levodopa in the setting of Parkinson's disease. Another thing that I see usually with Amantadine after months or years of Amantadine, and when you increase the doses from actually 200, more than 200, I don't know why is that, but after 200 you see what we call livido reticularis, which is some discoloration in the skin, like a purple discoloration. So nothing bad about that. It doesn't look good, let's put it that way. Okay, so sometimes if it's very mild, I don't do absolutely nothing because the medication is working for them. You just have these skin lesions, and sometimes what I have to do is just to decrease by 100 milligrams, and that's it. One important detail of Amantadine is that you have to take it early in the morning when you wake up, and not before 2 p.m. assuming that you go to bed at 10 p.m. Why? Because it might cause insomnia. Okay, insomnia. So I tell patients that usually to take it before 2 p.m. and even earlier if it's causing insomnia because of this problem. And sometimes a good dose, I consider a good dose, is to take it 200 milligrams in the morning and 100 milligrams at 1 p.m. More or less. Okay. Another detail very important that you need to know about this medication, especially if you go to the hospital and you are admitted to the hospital due to dehydration and you have renal failure, the problem with this medication is that this medication is eliminated by the kidneys. So which means that if you have renal failure, if your kidneys are not working well, you will accumulate this medication in your system. So you will be kind of jerky, very confused, and even your speech, we call that dysarthria or slurred speech. And the only thing that you have to do in those patients is just to decrease the Amantadine. Maybe 50% will be enough, because you need to adjust the doses based on renal function. Now, another option that I have for you, and again, everything depends on your comorbidity, age, and other factors, is the use of dopamine agonist. Dopamine agonist. So remember, there are different ways to improve dopamine in the brain. So, and this is one of them. So these medications, this type of medication, go directly to the receptor. Okay, it's a dopamine agonist. I am not a fan of dopamine agonist because of the side effects. So initially, when this type of medication came back in 2002, 2003, everybody was excited about this medication, but during all these years, we know that there's a lot of side effects. I have a video talking about the side effect of dopamine agonists that you should know. And some of them are very bad, especially the compulsive disorder that is very common. Compulsive disorders. sleep attacks. So imagine that you are in the traffic light and you fall asleep, and it's probably because you started this medication. Okay, so you have to be careful with this type of medication, but still they have a role in Parkinson's disease. So when to use this medication? For example, if I have a young female, imagine that I have a 40 years old female with Parkinson's disease, with history of depression, pain, and restless leg syndrome, RLS, and no history of addiction or compulsive disorder. This is the case to use this medication. Okay, this is the case to use this medication, this type of medication, and I will use pramiprazole, or better, if I can, because the cost, is the patch, which is a Nupro patch or rotigotine patch. That's the way to go. So, in other words, if you have a patient with history of compulsive disorder, addiction, sleepiness, daytime sleepiness, very common in Parkinson, and leg swelling, don't use this medication, because this medication will cause worsening of those symptoms that you have those symptoms already. So don't use this medication. Try to find something else. I am not mentioning some oral medication because they are very expensive or minimal effectiveness or side effects, and the side effects outweigh the benefits. For example, I did not mention this one. You're going to see in the screen. It's very difficult to pronounce, but let me try. Nouricians. I don't know how to pronounce this word. Nouricians, but anyway, it will be here. So honestly, I only have one patient taking this medication, and it's because the patient has a grant. And lately, I have to stop the medication. I have to tell the patient to stop the medication because the patient is having hallucinations, and this patient is taking carbidopa, levodopa, obviously, because it's the main treatment. So you start cleaning the patient. Basically, at this stage, when you have advanced Parkinson's disease, you try to simplify things. So you try to eliminate medication. So the patient is having hallucination, chronic hallucination. So this is not due to infection, acute infection. It's because the patient have Parkinson's disease and medication are exacerbated those symptoms. So you start cleaning the patient and you start eliminating the medication. So that's the medication to eliminate. In addition to other medication that, for example, Amantadine, that this particular patient is not taking Amantadine. But if the patient were taking Amantadine, then Amantadine have to be eliminated. Okay? So this medication, Nouricins, reduce the daily time of approximately 0.7 to 1 hour. And then give you all these medications that you add on, give you approximately 1 hour extra on time. Almost all of them. Some of them 45 minutes, some of them 50 minutes. That's the average. So the problem is that they are very expensive. So I rarely use them. The other type of medication I never use, especially in 2025. Not even in patients with significant amount of tremors, is those medications that are anticholinergic medication, anticholinergic effect, very strong anticholinergic effect, such as Artine and benztropine. You will see the name here, Artine and benztropine. Those medications were used in the past to treat younger patients with tremors and drug-induced Parkinsonism. I don't use those medications anymore. If all the steps that we discuss is not helping you and you still having significant wearing off affecting function, then you need to consider infusion therapy. So your provider play with all the oral medication, by MAO medication. Now there is other option, which is infusion. So specifically, I will be talking about this new Levodopa formulation, which is Sub-Q, approved by FDA last year. The name you will see in the screen, which is Vyalev. So this is a sophisticated Levodopa. It's actually foslevodopa Sub-Q, so it's through the skin. Imagine that it's like having an insulin pump, but it's not insulin, it's foslevodopa. However, very expensive, obviously, very expensive. Anything new is gonna be very expensive. Your doctor, your Parkinson doctor, your neurologist need to document that you have advanced Parkinson disease with significant motor fluctuations. Specifically, need to document at least 2.5 hours of time per day. And sometimes that might not be enough, and the insurance will give you a hard time. And also that the problem cannot be managed by optimizing oral medication. So that's a very important thing that we need to document on the chart. And make sure that you understand that this is not magic, okay? That might give you an extra close to 2 hours on time when you compare with the IR, but still is not magic. There is nothing that we can do to stop the progression of the disease. At least still not in 2025. So, and the doctors or providers who are telling you that I have a medication that can stop, that can cure Parkinson's disease, be careful with that, okay? Because there is no evidence for that. You have to be careful. Now, remember that because the medication is through the skin, what is the most common side effect? Skin lesions. So the majority of the patient will have something in the skin, some skin lesions. Many times require that you discontinue the treatment because skin lesions, and not only that, infection in the skin. So you have to move the catheter, because it's a tiny catheter in the skin that you put around the umbilical area and your abdomen. You have to move this catheter every day, every 2 days, every day. We usually recommend every day. So this is very similar to Duopa. However, in Duopa is more invasive, because in Duopa you have to put a PEG tube. This goes directly to the area of the intestine that it get absorbed, the Duopa. So I don't have any patient with Duopa currently. The last one, we had to remove the Duopa because of infection around the PEG tube. So we had to remove the tube. So that's why I'm not going to talk about that. If I'm going to use a Levodopa infusion, I will use this new treatment, which is the Levodopa, foslevodopa Sub-Q. There is another type of infusion, which is not Levodopa. It's actually a dopamine agonist, and the name is Anapgo. I don't know if I'm pronouncing correctly, but you will see the name in the screen. Anapgo, which is a Apomorphine Sub-Q pump. Apomorphine is a dopamine agonist. Remember, I told you that I'm not a fan of dopamine agonists, but this one, Apomorphine, is very potent. So it's the second most potent medication that we have to treat Parkinson after Levodopa. Remember, there is nothing better than Levodopa, but this one, very close. But again, it is a dopamine agonist, so a bunch of side effects that you get. Plus the skin lesion that you can have, like approximately 60% of the patient, they have some skin lesions based on the trial that you have using this medication as well, like any other Sub-Q medication. So I'm looking forward to try this medication. Like I say, I don't have any patient in this type of pump, but it has to be the correct patient. The most common side effect beside the skin lesions, like any other skin or Sub-Q pump, is nausea and vomiting. And that's why you have to pre-medicate the patient before starting this medication. Okay, very important. Now, I did not talk about rescue treatment. So rescue treatment are the treatment that you use when you have sudden off, that you need to use something that work faster, quick. So sometimes what I tell patients is to prepare the Levodopa homemade. So I have the video explaining how to do that. But many patients don't want to do that, and they prefer a medication like what we call inhaled Levodopa, Inbrija, or something that we call, again, Apomorphine, but this time sublingual, the name you will see in the screen. Again, those medications are very expensive and approved by FDA for sudden off, because they tend to work faster, 10 to 15 minutes, 10 to 20 minutes, depends of the medication, but that's the average. They're pretty quick. Now, to finalize, let's talk about the most effective treatment that you have to treat motor symptoms in Parkinson's disease, especially tremors. I'm talking about deep brain stimulation. So deep brain stimulation is the best treatment that we have available to treat motor symptoms in Parkinson's disease. There is no question about it. The problem is that it's a surgery, so you have all the risk that you get every time that you get a surgery, ankle surgery, knee surgery. You have risk. Life is about risk. But there is no doubt that in the correct patient, and that's why patient selection is the most important factor for success when we talk about deep brain stimulation, is this type of treatment. Okay? So the most effective when you are wearing off, the most effective when you have dyskinesia, and the most effective by far when you have tremors. There are patients that you can play with medication, with Levodopa, you can go up with the Levodopa, and it's not going to touch the tremors. It's not going to touch the tremor. Help with the stiffness and the slow movement, but the tremors didn't touch. So those patients actually might respond to Levodopa. I'm talking about the tremors. Very effective. However, not everybody is a candidate. Not everybody is a candidate. We do not put DVS in patients with dementia. Why is that? Because you need to have enough cognitive reserve, just in case if the surgery causes you to have more cognitive issues. Usually verbal language is getting affected. So that's why it's very important to make sure that you don't have significant cognitive issues affecting function. We call that dementia. We don't do that. Okay? Many patients still with mild cognitive impairment, still they can have deep brain stimulation. But we prefer intact cognition. But it's usually we know that even from the beginning, people with Parkinson's disease, they can have mild cognitive impairment. So there are patients that, as long they have the other good requirements, they might be a good candidate, even with mild cognitive impairment. The only thing is that sometimes we select a different target, and instead there are two targets in deep brain stimulation: the GPI, I'm not going to talk about in details about that, and the SDN. So when you have patients with significant, I don't want to say significant, but at least mild cognitive impairment, and you are thinking about deep brain stimulation, the way to go is to use to use the target. GPI has a target. Okay, this is what we usually decide when we are in the deep brain stimulation meeting. Now, it is very important that the most important factor, like I mentioned before, is patient selection, and that's why you need to be evaluated by a good team. And I always say that good team means at least 3 movement disorder fellowship trained neurologists, in addition to obviously the surgeon. The surgeon has to be, in my opinion, a fellowship trained neurosurgeon in functional neurology, functional neurosurgery. Functional neurosurgery are the surgeons that are trained in doing this type of procedure, like deep brain stimulation. They spend at least 1 year doing that in training. So that's the expertise that I will look if I have Parkinson, and I'm considering doing deep brain stimulation. Why? Because this is permanent. So they're making holes in your brain. So this is not like I'm going to give you a pill, and if the pill costs you side effect, you put it in the garbage and that's it. No, this is a surgery. Okay, so you need to be clear and understand the risk and the benefits, and make sure that the team, they have done this for a long time, so they're not new doing this. Okay, very, very, very important. So, in other words, and just to summarize and to finalize this, before considering deep brain stimulation, right, you have to try all these things that I mentioned before, right? Then you need to have at least 4 years or 5 years, at least 4 years with the disease before considering deep brain stimulation. So you cannot do, at least not for now. I don't know if things might change. You need to wait 4 years because things might change. You need to be sure that you have Parkinson's disease, because there are many diseases that looks like Parkinson's disease, but they are not Parkinson's disease. And sometimes they look very similar during the first 5 years. Actually, there is a study that showing, I think the study was published in 2016 or 14, showing that doctors during the first 5 years, they are right 50% of the time when they make the diagnosis of Parkinson's disease. That's why you had to wait at least 4 years, 5 years before taking a decision of making 2 holes in the brain, in the head, to put these cables. Okay, so you had to be clear about that. So 4 years with the disease at least. You need to pass Levodopa challenging test. So which means that your doctor, your provider, or sometimes a physical therapist can do the evaluation as well. It gives you high doses of Levodopa. High doses means that they double the dose of the typical doses that you take at home, just to make sure that you have a good challenging test. And you need to improve at least 30%. The insurance need to see that, unless you have a tremor predominant Parkinson's disease, which it might respond very well as well. But we like to see at least 30% improvement off compared to on. Okay, and you need to pass the neurocognitive assessment, and you need to have a good health. So we are not going to do any surgery in somebody who is unstable from the heart. Okay, and very important, if you have depression, which is a very common thing in Parkinson, you need to be stable emotionally. Okay, you need to be stable. So and before I forget, you need to have realistic expectations. So you need to be realistic. This is not a cure. This is going to improve your quality of life. Okay, very important. If you expect that this is going to cure you, or this is going to stop your symptoms, you are not going to be a good candidate. Okay, don't do this. If you like this video, don't forget to subscribe to my channel. Click the like, share, and see you soon. Take care.